Today, our guest is Dr. Veena, BHMS, consultant homeopathic physician, Hyderabad. More than 10 years of experience. The topic is homeopathy in long-term complications of COVID and COVID vaccines.
So we have been continuing this topic, I think, for the past 2-3 weeks. So it's on COVID and COVID vaccines. So what can we do with homeopathy in COVID and COVID vaccine related long-term complications? So we all know acute disease is very well managed by homeopathy. So what about the complications? And what about the side effects of the vaccines? This is what we are going to discuss. And I think a lot of medicines been discussed in the last 2 weeks. So I'm trying to give an insight on why complications are so critical in COVID and COVID vaccine related, and what are the tests or what are the laboratory investigations we can use to which would be helpful for us to arrive at the prognosis and also the diagnostic part. So these are a few of things which we are going to discuss today. So coming on to this, so what made me to go in deep about this topic? Why I learned so much on this topic is because my brother, that is my cousin brother, we lost him to for massive cardiac arrest a couple of weeks before. So not sure what was the reason for the cardiac arrest, but when I am continuously listening to the seminars in IFPH, I had a thought probably it may be of COVID and COVID vaccine related as well, because he was only 32 years old and suddenly he ended up with a massive cardiac arrest and he succumbed to it. So it was very painful for us, and it made me to deep dive about this COVID and COVID related complications. So I dedicate this session to my brother. His name is Sri Ram Radhakrishnan. So we all know COVID is a virus, and this virus gives a lot of symptoms, and mostly it is presented as pneumonia related. So how is it getting presented? So what is the difference between other pneumonias and the COVID pneumonia? So how are we going to differentiate these two things as in a clinical point of view? So other pneumonias, it's very acute, it is self-limited. So there is a prodromal phase, there is an active phase, it reaches a peak, from there it comes to a decline. During the decline, either the patient recover or they may succumb to the ailment. This is how any acute disease is getting presented in a person. So in other pneumonias, the pneumonia is presented as acute, and it has a self-limited disease. So when you see the presentation, when you see the CT or X-ray chest, we can see there is a acute development of the symptoms or the invasion into the lungs unilaterally, but the spread is very fast. So the virus invades the lungs, and there are immunological reactions, and because of the reactions, there is a pneumonia-related changes in the X-ray. So the X-ray findings are very clear at the very early stage itself. Probably 1 or 2 days itself, when they develop the cough and other symptoms, the X-ray is evident with the pathological stage. So what are the 4 stages in acute pneumonia? We have congestion, red hepatization, gray hepatization, and there is a resolution phase. This is how it get presented. When you take a CT chest or a X-ray, these 4 stages are evident. So this is how it is getting presented. So what is the difference between COVID and other pneumonias? COVID, it takes some time to invade the lungs. So how is it presented? It is relatively slower to establish the infection. So what it does, like we all know, every virus have a different pattern of invasion in the disease pattern. In case of HIV, it is attacking the T cells. Likewise, in COVID, it is attacking the immune system, and it is developing reactions in the lungs, due to which there is an alveolar damage, and there are multiple other organ invasion also that we will discuss at a later stage. So here, when you check the other pneumonias, mostly it is unilateral, and it is intensive in the one side of the lungs. This is how it is presented. But in case of COVID, it is a bilateral extensive involvement, and there is a preponderance of the lower lobes of the lungs. So what happens is it settles, it triggers the immune system, it goes, attacks the immune cells. There is some pathophysiology happening within the immune system, which ends up in the stages of the disease. So 0 to 4 days, we could see the ground glass opacities. 5 to 8 days, we can see crazy paving pattern along with ground glass opacities. Then we have the peak phase, where these ground glass opacities have a hollow sign, that is between 9 to 13 days. So this is where they develop critical symptoms. They end up in ICU and other complications. So, and there is an absorption phase where which is above 14 days, where we have the ground glass opacities and other consolidation related changes in the lungs. So generally we say RT-PCR. So RT-PCR test is sometimes positive, sometimes negative, even in a COVID case. So where do we rely upon? So what diagnostic tool we can rely upon? The most reliable tool would be the HRCT, high resolution CT chest. So what are the stages involved in this? So when you go to the stages, so this is how it is presented. We have early phase like this, where the lungs is clear. We can see multiple scattered ground glass opacities, which is bilateral. See the red arrows, you will be able to see that. So here, either the throat swab may be positive, or the RT-PCR may be positive, and sometimes it may be a suspected COVID also. But when you take a HRCT, and we will get to know that these ground glass opacities are mostly on the lower lobes. Here also it is in the lower lobes, and it is on bilateral. So this is within like exposure, immediately after the exposure. Then we have the next stage, early stage, we have the ground glass opacities, which is more visible, which is extensive on both lobes. Here they have shown only one lobe. Then there is irregular interlobular septa, which is getting developed. See, there is a V pattern here. That is all interlobular septas getting visible in the HRCT. And we have a rapid progression stage. Here, see, we can, by seeing the images, it is very clear how it is progressing from one stage to the other. So this is not very slow. It may happen within hours also. Though they say 3 to 7 days, after 3 days, the progress of the disease is very fast, that we can't predict how fast it will be. So there is an escalation in the hyperinflammatory response, fibrous extension that connect the alveoli begin to develop. So this is how the staging is in the both the lungs in case of progression stage. So the virus has invaded, it has established an immune response, and because of the immune response, there are some changes in the HRCT. So this include subpleural posterior consolidation with superimposed images. Then we have the consolidation stage. This is in the second week. So slowly, this is a recovery phase. So in this, slowly it is getting recovery. There is a decrease in size and density of the consolidations. Then it about 2 to 3 weeks after initial symptomatic presentation, there is healing and repair. So this shows patchy consolidation, reticular opacities, bronchial and interlobular septal thickening also there. So after that, slowly it will take months together for the patient to recover from the symptoms and all those things. So this is how we can capitalize on the CT, HRCT chest. So to have a better view, see, I have given a enlarged image here. So this is the earliest stage where there is a ground glass opacity alone. Here there are bronchiovascular markings more, extensive ground glass opacities, and it is invading more. There is a progression of the disease, then there is a resolution slowly. I hope the scanning image is very clear. So if we have a, see, again, there is a surge of COVID. So we can see many cases who are suspected COVID or RT-PCR positive. So to assess what stage the patient is, we can capitalize on these diagnostic tools. And upon treatment, if we repeat the HRCT chest, we will get to know how it is resolving, what is the end stage of the lungs after giving treatment, homeopathic treatment. So this was regarding the diagnostic tool. One is the HRCT. So then we'll go to what is happening in this COVID. See, why I am trying to give this pathophysiology in case of COVID is, see, this has a similarity with the COVID vaccine related complications also. So what happens is majorly we have a coagulopathy. There is a imbalance in the hemostasis. That is the blood clotting. There is a imbalance. So that is one thing which is happening. There is an inflammatory reaction because of the invasion of the virus, especially the spike proteins. Then there is a alveolar damage. So because of the alveolar damage, we have microthrombus, which is in the capillaries, alveolar capillaries, and we are even witnessing neovascular genesis also. This both are enhancing the alveolar damage, and they may develop into ARDS, that is acute respiratory distress syndrome. So altogether, because of the inflammation, there is a cytokine storm. So this is a new word to us. So we know that cytokines are involved in case of inflammatory stages, and we have even heard about some interleukins, tumor necrosis factor, interferon alpha, gamma, 1, 2, 3, all those things. These are all responsible for the inflammatory reaction. So whenever a pathogen enters a cell, so there is a reaction to it. So the body tries to exclude the pathogen which has invaded the cell. So this cell is reacting. So this is a normal phenomenon. So what happens in COVID? So COVID protein is a foreign body, so for which there is an inflammatory reaction. During this inflammatory reaction, what happens is there is a cytokine storm. That is, there is a hyper stimulation of the inflammatory reaction there. So which actually helps the body itself to destruct its own cells. So that is how it is ending up in alveolar damage and the ARDS in a later stage. So what is happening is the interferon 1, it is getting weakened. So what happens? There is a viral replication. So when there is more replication of virus, there is a more chance of or increased stimulation of the immune response. So what happens? There is cytokine release, especially interleukin 6. There are many hypotheses behind this. It's developed in COVID. They are stating 3, 4, 5, 6, many kind of hypotheses how it works, why the inflammatory reaction goes in such a way. So they say that the cytokines interleukin 6 is one of the major factor which is contributing to the excess inflammatory response in case of COVID. And they also say there is an antibody which is binding to the S protein of the virus. So which creates an immune response, and there is apoptosis. Then there is death of cells, and there is a microthrombi also getting involved. So this thrombus may go to other organs, and it may lead to MODS, that is multi-organ dysfunction syndrome. So when there is extensive cell death, there is release of LDH also. So why I am giving more importance to these things are, like, these are key factors or markers to identify how the COVID is prognosing or what will be the long-term complications for the particular patient. To identify these things, these key markers will be helpful for us. So they also say there is an hypothesis that there is a angiotensin converting enzyme 2 receptors. So this also will contribute to the organ damage. Then there is another hypothesis in which they say antiphospholipid are getting activated, which in turn produces more platelet hyperactivation. So which leads to, actually, this is regarding the thrombosis concept, what is getting evolved. So after the platelets are hyperactivated, then there are anti-platelet factor 4 antibodies getting released. So this is one antibody which goes and binds with the platelets, and it increases more coagulation and thrombosis. And this has a tendency to cross even the brain barrier and even lead to brain damage. So these are the key factors. So we need to just have a look on the normal values. So what tests could be helpful in identifying whether the patient is going for further complications or just limiting himself to a pneumonia and a recovery. So these are the few tests. One is D-dimer. The normal ranges, which is less than 0.5. If it is more than 0.5, then it indicates there is a clotting imbalance in the patient. Then we have the ferritin. Ferritin, generally, there is a normal range difference between males and females, but generally speaking, if it is less than 300, it doesn't have any significance. It's more than 330. So mcg per liter, then it says that it is above range. And you can see in patients who are developing ARDS and other complications like cerebral venous thrombosis and cardiac related ischemia, they will have more levels than this 330, what is the normal range. Then we have the fibrinogen. As we all know, fibrinogen is involved in the clotting. So when there is above 400, it is said to be, again, there is a imbalance in the hemostasis. Then CRP is a very good indicator. As we all know, see, in any infection, this CRP is getting elevated above 1 milligram per liter. We get to know that there is an infection and inflammatory reaction. So any inflammation, we have the CRP raised. Then, as we all know, when there is a cell death, there is an increase in the LDH levels. So LDH levels, when they increase, again, there is an imbalance in the hemostasis. Then some say, like, we can even check the interleukin 6 levels in the blood, which may be a key indicator whether there is a cytokine storm or not. And especially in case of vaccines, they say anti-PF4 antibodies, this will be elevated more than 0.4 or more than 1, which is highly risky. The patient may anytime end up with brain damage or cardiac damage or any other multi-organ damage also. So these are the key indicators. So there are many hypotheses which is not concrete, but still these markers are highly helpful in understanding in what stage the disease is, or in which kind of patients end up in more complications. So there is a cohort staging. So initially we didn't have much studies about, like in 2020 beginning, we never had much idea about how they are staging the disease, why they are complications, why they are ending up so severe disease and people are succumbing to the disease. So later, slowly they started staging it, and it is very helpful. So when you see the CORAD score in the HRCT report, the CT severity, with that we can understand where the patient is at that stage when they come to the treatment. Generally, if a patient is with allopathy, I don't think, especially in case of Hyderabad, I don't think they are taking to consulting other systems like homeopathy. But in Kerala and Kolkata, I believe even in Maharashtra, most of the people, they have an integrative approach. They either take homeopathy or homeopathy and allopathy together. So this may be helpful for us to understand the staging. So non-infectious stage, they still give CORADS 1. CORADS 1, we should not think it is a COVID positive. No, it is a non-infectious or a normal stage. Then we have the CORADS 2. It's typical other infections. It is not COVID-19. So from 3, they are staging. So in these ground glass opacities, bilateral and other changes, whatever we have seen in the CT report, they stage from 3 to 6, 3 to 5. So 3, 4, 5. 5 is very critical. So this is about COVID. So we all know how COVID is getting presented. The patient will come with fever, chills, cough, dyspnea. Sometimes even they are coming up with the SpO2 levels because pulse oximeter is available nowadays with everybody. So these are the initial symptoms. Slowly they will go to critical symptoms like dyspnea, non-stop cough, and respiratory distress. And apart from this respiratory distress, they also develop like myocarditis, cardiac ischemia, and even cavernous sinus thrombus. So these are highly critical, and they end up in CCU or ICCCU units. So recovery is very difficult, and at that stage there are other opportunities, opportunistic infections like nosocomial infections are also possible, and that is how they are ending up in other white fungus, black fungus, and other things. So this is a brief about what happens in COVID and what is the pathophysiology involved in COVID staging of the disease. So now regarding vaccination, so when they couldn't in the modern medicine, when they invented antibiotics, it was very helpful in curing the bacterial infections. When they found antifungal, it was very helpful in that. But when they couldn't give an antiviral, then they started exploring about the vaccines. And we all know after Jenner, smallpox, polio, all these things, this vaccine program has been implemented after that, and it has been successful in most of the cases. But what about the complications after vaccination? That is one gray area which is not much actually dealt with by the modern system of medicine, because the simple logic is crores of people are getting vaccinated and crores are getting benefited. So why bother about this? Some people who are getting complications or adverse effects because of the vaccine reaction. So, but all these years, the vaccine invention is like they had a program of like they tested in animals, then slowly they tested in humans, first stage, second trials, third trials. Then only it takes almost like 4 to 10 years of research work to bring a vaccine to the market. So this is how it works. But in case of COVID, because of the extensive criticality on and the pandemic spread of the infection, made them discover this vaccine faster, and they put it in faster trials, and it has come to the market at a very faster pace. We couldn't even imagine in what pace it has come. Definitely, they say like though they are getting infected after vaccine, but the criticality or severity of the disease is less after vaccines. This is what they claim about. But long-term research to be carried out to find out whether are there any adverse reactions to this vaccine or not. Because now whatever clinical trials I have seen is either they are not published the results or still it is ongoing, and those results are not very much evident in the internet available for the public, because it may curb the intake of vaccine among the public, and which may ended up as per modern medicine, which may end up in more casualties and death. So that is how it has come to the market. But a serious thought when I have given on this, I've seen like when a polio vaccine in particular area, when they gave in US, when there was a shed of the virus and the attenuated virus got virulent, they stopped the vaccine program for almost a year. This has happened. So one case, when it reported with a virulent virus, they immediately stopped the vaccination. This is how critical it is. When a vaccine is failed, it has got a huge impact on the public. So we have to be very careful on this vaccination program. Is of course, when the government has put restrictions on travel and other things, it becomes a mandatory. But still, either at least we should have an integrative approach here with Ayurvedic or homeo treatments, so that they don't end up in complications at least. So this is one area where we have to create a lot of awareness among the public, so that they are welcoming the system to take medicines against the vaccine and or COVID long-term complications as well. So as we all know, there are some types of COVID vaccination, like mRNA vaccines are there, adenovirus vector vaccines are there, inactivated viral vaccines, and vaccine. So what happens with all these vaccines? See, this mRNA is a direct loading of the RNA into the cell. Adenovirus vector vaccine, there they take the help of the adenovirus, in which they have loaded the spike protein, that is the COVID virus spike protein inside the virus, and they inject the adenovirus. So inactivated viral vaccine, that is the attenuated viruses. This is in the Covaxin. So Covishield and Covaxin, these are the major vaccines which is being given in Indian vaccination program. So what happens after a vaccine is given? So it induces an artificial immunity or immune response in the body, wherein the antibodies are created by the body, and they identify the virus when the virus enters the body. This is the logic behind any vaccination. So what happens in COVID-19 vaccine? So majority, they have a mimicking symptoms of COVID-19 or a pseudo-vaccine infection, pseudo-COVID infection as well. This is what is being observed as an adverse reaction in case of COVID vaccination. So we know the complexity of the pathophysiology here. There is a coagulopathy, there is an inflammatory damage, there is a cytokine storm, and there is an alveolar damage because of the microthrombus and also because of the cytokine storm and the hypothesis, whatever we have dealt with here. So this, when it mimics the syndrome, it has an extensive effect on all the organs. So it may just create an immune response and create an antibody, and the body becomes ready for when the COVID infection is encountered. This antibodies goes and attacks the virus, and the virus is easily curbed by the antibodies which was created by the body. This is the usual response what we are expecting. But since this COVID itself has got a lot of extensive involvement of different organs, the same thing might happen with the vaccine also. There is a threat. There is a risk as well. So they always, the modern medicine always weigh with the statistics what they have, and they say like in crore people, if only 200 or 300 or 2000 or 20,000 patient is getting affected, that's not much of a difference. So better for a greater good, you just give the vaccination. This is how it's planned. So this is one critical complication after this COVID vaccine, which is called the TTS, that is thrombotic thrombocytopenic syndrome. So what happens here? So there is a thrombocytopenia, that is the platelets are becoming less because of the destruction or the cytokine storm, which is getting involved because of the immune response, what the COVID spike protein is able to bring upon in the body. It may be vaccine, it may be the COVID virus itself. So in both the cases, this reaction is possible. So once there is a thrombocytopenia, there is a higher chance of this thrombosis or thrombotic syndrome. So what does it do? It creates the alveolar damage, and from there these microthrombi go to the pulmonary embolism, and this embolus can pass to any of the organs in the body and or all of the organs and create a MODs, that is multi-organ damage. It may create an arterial ischemia also. So in this stage, what are we expecting in the blood report? So we'll have a high level D dimer, we have a low fibrinogen, there is hyperfibrinolysis, then there's antibodies binding to the PF4, that is a platelet factor 4. That is also elevated in the blood, and interleukin 1, 6, and 17A, these are supposed to be increased in the blood. And we have plasmogen activation inhibitor 1, which is getting suppressed. Instead, there is a different pathway, which is UPAR. This is urokinase plasmogen activator or activator receptor. So these two things getting hyper elevated, and there is more fibrinolysis, fibrin deposition, hyaline membrane formation, and there is microvascular thrombosis. This microvascular thrombosis is the catch here, which leads to a long-term complications in COVID, or the patient succumb to these type of thrombosis only to death. So it may be at only the alveolar level or at the other organs also. So these two things we have seen, like what happens in COVID complications and what happens in COVID vaccine related complications. So the life-threatening complication is the thrombosis, involvement of cytokine storm, that is a hyperimmune response. So they may end up in a chronic fibrosis kind of things in the lungs, and they may end up in dyspnea, allergic reactions, hypersensitivity, or they may end up in a myocarditis and other things. Though they say after vaccination, whatever has been reported on myocarditis or other ischemias, they're very meager and they resolve by itself, but still it is an adverse reaction. So if when they study a vaccine related complications or adverse effects, they take a window of like 30 days to for example 6 months or 1 year. This is what study I have seen as for now. So when we are speaking about long-term complications, there might have fibrous lung which is lying there itself, and it may create a long-term lung like COPD kind of problems in the individual, or it may have a thrombus, and this myocarditis or endocarditis, this may stay lifelong, or the ischemia which has brought some changes in the cardiac or any other tissue will have an impact on the individual. So whether COVID or in COVID vaccine related complications also, we can expect both these things. So what are we going to do? So I gave a deep thought on this, and when the government is imposing something indirectly, now they are saying we have not imposed, it is your interest to take a vaccine. But when they put a travel restriction, they across borders, even between states, then it is implicit that it is indirectly forced upon the public. So what we can do with homeopathy? Earlier, we had a genus epidemicus for the COVID infection. So we wanted to encounter the COVID. We extensively studied what were the symptoms, and Arsenicum album was given us the genus epidemicus across India, and it was fruitful. We fetched fruitful results with Arsenicum album. So in case of vaccine or COVID related long-term complications, I think we should have a proposal of how to encounter. If we have regular patients, we can definitely go to the individual prescription. We can base it on constitutional, or you can take an acute totality, or if the patient is periodically visiting you, you can take the case then and there and can accordingly assess the patient, find a totality, arrive at a minimum and give it. So this is the classical method, and this will be the standard and excellent method which will be helpful in the patients who are walking into the clinic periodically, or the members of our family. It is very easy. They might not be under our treatment, but you can you know about them, and you can give these medicines on a periodical basis whenever necessary in SOS basis. So there is no alarm. Still, I would suggest a rescue remedy, the flower medicine, to be in hand with everybody, your patients, your family members, everybody to be in hand, so that if they develop any symptoms suddenly, they can take rescue remedy, and so that they can reach the hospital and find the appropriate therapeutic assistance. Thereby, they are not in immediate harm or risk. Then when we come to the mass prescription, so they come to your counter just to take a see, now again there is a surge in COVID, they will definitely walk in for COVID preventive medicines. Then we should have a proposal like how to encounter this. So since last 1 year, I have been using this Arnica 30 or 200. So we asked like how we were prescribing Arsenicum album. We started prescribing Arnica, and we don't know about the results, but whoever is walking in again to the clinic for the next dose, or whenever we give, like after 2 months you come and take the next set of medicines, they may come, and we have found that it is very fruitful and it is helpful, and they have not developed any sort of complications regarding thrombosis or anything after the vaccination also. So this Arnica, I think we can use it as a genus epidemicus. Then in case of this thrombosis, the hemostasis imbalance, I think that has a tubercular miasmatic background. So I would suggest a tuberculum intercurrent also to prevent the COVID long-term complications also, and also vaccine related. But in highly sensitive patients, we can even try the 0/3 instead of trying 200 or 1 potency. Then especially the vaccine-induced complications, I think there is a logic of giving a Silesia. Silesia rejects any foreign body. Here, there is the spike protein which is getting injected to every individual in the name of vaccine. So to eject that from the body, I think Silesia is a wonderful medicine, and we can try that also in 30 or 200 potency. 30 being highly suppurative, so I would suggest 200 will be the moderate potency to give vaccine induced or vaccine related. So we can always ask them what kind of symptoms they developed immediately after vaccination. What all they developed, whether there was any palpitation, any cardiac symptoms, where they've been taken for ECG or something later within weeks after vaccination. Accordingly, we can again arrive at a totality and give an acute totality prescription against the anti-hemorrhagic tendencies in that patient. So in our literature, there are many anti-hemorrhagic remedies, and we can think about Proteolus horridus, Bothrops, Naja, Lacosis, Phosphorus, Arsenicum album itself. These are very good medicines which we can prescribe on an individual or an individual totality basis. So this is my thought process on COVID and COVID related complications.